Hi, I'm Richa Malhotra from 4Base Care. On behalf of 4Base Care, I would like to welcome all of you on the Precision Oncology Asia webinar series. On account of October being Breast Cancer Month, Precision Oncology Asia is also going pink. Today, we are bringing you an exciting panel discussion by a group of eminent oncologists to discuss the challenges and management of triple negative breast cancer cases in Southeast Asia. Now, I would like to take this opportunity to introduce and welcome everyone in the team uh, from the panelists and our moderator, Dr. Sandeep Nayak. Today, we have with us Dr. Sandeep Nayak, who will be moderating and opening the session. I would like to extend a warm welcome. Because he has taken our request to moderate this exciting discussion on treatment and management of TNBC. Dr. Nayak is an international renowned surgical oncologist who is also known as pioneer of robotic thyroidectomy and minimum invasive neck dissection in India. At present, he is the director and head of Department of Surgical Oncology at Fortis and Max Hospital, Bangalore. Dr. Nayak is a recipient of multiple awards and recognition, which also include the Times Health Excellence Award 2018. He is also a member of Royal College of Surgeons and part of ESCO committee. Moving on to our group of panelists, we have Dr. Ahmad Rahman, who is a consultant medical oncologist and founder of Cancer CRI Center, Malaysia. His area of interest are immuno-oncology, precision or genomic cancer, real-world outcome studies, and cancer treatment. His vision is to advance the cancer research in Malaysia and Southeast Asia region through borderless network and collaboration. We welcome you, Dr. Rahman, for this discussion. Moving on to the next second panelist, Dr. Sandeep, Dr. Mandeep Singh Malhotra. Dr. Malhotra is a surgical oncologist and who is presently working with Fortis Hospital, Basant Kunj, as a senior consultant and head of department. He is also one of the co-founder of Art of Healing Cancer, which is an initiative to boost the standard cancer treatment with metabolic therapy. Then I welcome Dr. Necy Juat from Philippines, who is an experienced medical oncologist, currently practicing at the Medical City and National Kidney and Transplant Institute, Philippines. Her specialized area is in precision oncology and clinical trials. Moving to the next panelist, I would like to welcome Dr. Nuradh Joseph from Sri Lanka. Dr. Joseph is a consultant clinical oncologist currently working with Ministry of Health, Sri Lanka. He is a vice chair of Sri Lanka Cancer Research Group and has multiple awards to his credit, including the prestigious Helen Peterson Prize by British Uro-Oncology Group for his amazing research. Then I would like to welcome our next panelist, Dr. Sewanti Limaye. Dr. Limaye is an international renowned medical oncologist practicing at Kokilaben Dinurbai Ambani Hospital in Mumbai. Her expertise lies in the medical treatment of all solid tumors, including head and neck, lung, breast, and sarcomas. In addition to chemotherapy, she also specializes in cancer genomics, targeted therapy, and cutting-edge treatment with immunotherapy. She has done extensive expertise in genomics-driven approach or precision oncology for the treatment and management of cancer. She has been actively involved in clinical trials and has multiple prestigious awards in her bag. Welcome for the discussion, Dr. Limaye. Our next panelist is from Nepal, Dr. Sudip Shrestha. Welcome, sir, for the discussion. He is an executive chairman of Nepal Cancer Hospital and Research Center. He has also been actively involved since the establishment of Bhaktapur Cancer Hospital in Nepal, which is the second cancer hospital. He is a visionary and he is tackling cancer in Nepal for a long period of time. And he is also working towards bringing state-of-art technology for treatment of cancer, and bringing all the cancer facility in one room. Our next panelist is Professor and Dr. Chowdhury from Bangladesh. He is a prominent physician in the field of oncology who dedicates his time between clinical practice, training, consulting, writing, and multiple other work related to cancer. His current research interest is focused on quantitative analysis of breast cancer treatment outcomes in the clinic. He is also involved in Bangladesh Cancer Society and an also member of international organizations like ESCO and ESMO. Thank you so much for joining us for this discussion and giving us the precious time to discuss about it. Now I would request Dr. Nayak to take over the session. Dr. Nayak, please.
Thank you, Richa. Thanks for the introduction, because it saves me some time to do it, because I have a very eminent faculty with me today, and I going through the efforts to put together all the things and present is very usually difficult. Thank you for doing that. We have representatives from 6 countries, including India, and that is a very good set of panel, and we could have a varied views and our opinions and our way we practice. In fact, the entire setup of this panel discussion is around how we practice and what we do. That is what we want to understand. And in fact, very often what we notice is, what is put in the guidelines, which are generally international guidelines, does not apply totally to our practice, because those are guidelines made for some other population with some other realities in mind. So here in our discussions, we'll be discussing those aspects in detail and how in our practice we do things. So the scope of discussion, as I told you, is to look at the demographics and the regional practices. We will look at the guidelines and their glimpse, and then we look at the scope of cancer genetics in our practice. We are talking about our practice. Again, I'm not going to talk about the international things. I'm talking about predominantly what we do. Now, why is breast cancer so important? In fact, the importance of breast cancer is shown in this Globocon data. You can see the data. If you look at this, it is the most common cancer among women. It's about 25% of cancers among women are or is breast cancer, and it is one of the most common cancers when you take both sexes. In fact, it constitutes to 13%. Again, there is a variation between countries. This is an CR data, that is the South and Southeast Asian region. It's including both. So the data is quite clear, and the importance of this particular disease is also very clear. Now, I would be first trying to understand the demographics of what we are facing in each of the countries, and this will be a round table. I would pass this question around to all the country representatives, and we'll try to understand what they see in their practice. So this is, what is the age at presentation in your country? What is the stage at presentation? So I would start with Dr. Ahmad. He is from Kuala Lumpur. So how is it in Malaysia? What do you see? What is the age, and how do the patients present? What stage is more common over there?
Thank you so much, Dr. Sandeep, for the opportunity. Good evening, everyone. Yeah, so in Malaysia context, what we are seeing is about the same what you see across the Southeast Asia and Asia areas. So the population of breast cancer that we are seeing, a majority of them happen or occurred much younger compared to the Western population. So, the incidence for us would peak around 40 to 49 years old, as shown by our National Cancer Registry from the year 2012 to 2016. And this is at least about 10 to 15 years earlier than our European counterparts and also in the United States. So that's the first thing to take note. The second thing is about the stage of presentation. About 50% of our patients with breast cancer presented at stage 3 and stage 4, whereas about 50% presented at stage 1 and 2. This is actually when you cut across the national level, but we have to recognize that within our country, Malaysia, we do have the urban, suburban, and rural, also the socio-economic disparities across different states. So if you zoom a bit more closer to the East Coast area of Malaysia, we have about 70% of our population with breast cancer actually presented in stage 4 disease. So that's the context for the Malaysia locality.
How is it in Nepal, Dr. Sudip?
Yeah, I do agree with Dr. Ahmad. It is same as he said, but just to, note few of the points that unfortunately we do not have the good cancer registry. So most of our data based upon hospital-based registry, and recently piloted one population-based registry, which was completed in 2018, revealed that the age group, which is though in the hospital it is presenting in 40 to 50s is the highest number, but that urban-based registry has somehow showed some deviated data. That is the highest number being shown is 50 to 60, but I think that is some biasness must be there. And other than that, regarding the age, regarding the stage, the highest number of patients who are presenting to us is stage 2, very surprisingly. Probably because recently we have massively working on this cancer awareness program. So stage 2 cancer patients are nearly 65%, and stage 4 about 5 to 10. Rest are stage 1 and 3. So among them, the triple negative are 25%. So that is our data. Thank you.
So, okay, so you seem to be doing better. In fact, you're talking about the urban population, I guess, or across Nepal.
Actually, urban, yeah, because
urban,
most of the cancer registry is urban. Yes.
Urban only. Dr. Necy, how is your experience in Philippines?
Oh, okay. Good evening, and thank you for inviting me. We see a lot of patients in terms of the age, it's between 30 to 40. There's a increasing number of younger patients now. We also see patients at the age at the senior 55 to 60, less on the extreme age like the 70s. But in terms of the age, for metastatic, I think it's only 20%.
Okay.
We see a lot of early stage now because of the cancer awareness and the screening program. So I think most patients now are more empowered. They go to the hospital. If they feel something on their breast, they usually go to a hospital and check on it. So this one would be more of the stage. It would be stage 2 and stage 3.
Okay.
That's most of the patients that we see here.
You have a formal screening program, mammography and all that, or it's just that awareness which is bringing the patients?
Well, we have a lot of support group, especially for breast cancer. And I think one is they have this program in community health worker in a barangay. We call it in a barangay. They go to this barangay and teach them on how to do a self breast examination.
Okay.
We don't have but we do have a clinical breast exam as part of the government program. Mammography is usually on the urban area.
Mhm.
I think it's more of the education and um, educating the health literacy, I mean,
Correct. I
educating
agree.
the
Yeah.
patients and empowering them that at the age of 40, I should have my mammography, and
Correct.
during taking a bath, I
Yeah.
should do my self breast examination.
Yeah. That matters a lot, I guess, because in fact, mammography is, very often practically not possible in peripheries. It's very difficult to implement. It's not
Yes.
only getting the mammogram done, it is also interpretation of mammogram, which becomes very difficult in many of the rural areas. So that is why it is, self-examination and awareness has more importance than other places. Dr. Nurad, how is it in Sri Lanka? Dr. Nurad, you're on mute.
Yeah, sorry, yeah. So the in Sri Lanka, our median age of breast cancer incidence is 52 years.
Okay.
In terms of stage, we have about 14% presenting with de novo metastatic disease, and about 18% presenting with locally advanced disease stage 3. So we have about 24% presenting with at stage 1 and about 44% presenting at stage 2. So we are not quite as it doesn't quite mimic the European situation, but I guess we are about 68% of our breast cancer cases are either stage 1 or 2. In terms of immunohistochemical profile, about 30% are triple negative.
Okay. Yeah, we'll be coming to it after that.
Yeah.
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 Surely. So overall, I think it mimics similar. Dr. Chowdhury, how is it in Bangladesh? Is there anything you want to, tell differently from whatever other colleagues have told?
Yeah, in Bangladesh, as you know, we don't have the population-based cancer registry. We have a two cancer registry system, especially the National Institute of Cancer Research and Hospital, that has near about yearly 25,000 new cancer cases. And the Asan Mission Cancer Hospitals, where I usually presently I'm working, that has near about the 3,000 new cases, especially, and out of that, 1,100 as breast cancer. So most of the cases, the documented cases for last 10 years, which has been documented in the Medical Oncology Department of the National Cancer Institute, they found that stage 3 and stage 4 comprises now about 60% of the cases, because the patients are coming from the urban area, and stage 2 near about 20 to 20% cases, and stage 1 is near about 7 to 10%. That is the documentation from the National Institute of Cancer Research Hospital, the biggest one here, because we don't have the screening system in the Bangladesh. So patients which are coming from the remote areas are coming in the advanced stages, and especially the urban people are coming in a stage 2 and early stages. And regarding the age, actually what we find in the hospital, the average age is near about 40 to 55 years at presentations with a breast cancer, especially.
Dr. Mandeep, your experience in Delhi, and if you want to add something on India.
Thank you, Dr. Nayak. So my experiences will be as similar to yours, but in Delhi there is a slight younger age group. So I would say we are more into high incidence in 40 to 45 bracket. And still, being in Delhi, a very urban population, practicing in Delhi in urban population, still 50%, or I would say even more, are presenting in advanced stages. Around 40-45% is only in early stages, stage 1, stage 2. Still 50% plus are stage 3, stage 4. And also, there's one more thing I want to add, that I have felt that majority, like I would say, majority, I would say more than 50% of the women in North India specifically. So when I look at screening mammography, the breast density is pretty high. And their eligibility for screening mammography is really questionable at 40-45 years. So I agree with Dr. Nancy at Philippines that self-breast is a better modality. I really feel that.
Exactly. I think, in a way, I second that opinion as well, because in India, the breast density is a big hindrance. Has Dr. Sewanti joined? Dr. Sewanti is there?
Yes, sir, I'm very much there, yes.
Okay, okay, good. So you have anything to add from your Mumbai experience? How do you see?
Just
See,
that...
again, let me just put it across, India is a very big country. So, in fact, it's good to listen to various people from various parts of India as well.
Yeah, that's exactly my thoughts as well. I
Yeah.
feel that each one of the cities and states have their own catchment and referral basis, and awareness also varies. I haven't had a tremendous experience in India. I've only worked in Mumbai for the last 5 years. So my experience is limited to the corporate center. It's a quaternary center. We have a large catchment base, and mostly the gatekeepers are surgeons who are nationally, internationally renowned. So I get a very skewed population. I get most early stage breast cancers. Around 10% of the disease makes it into a metastatic disease, but mostly I would say stage 1, stage 2. Some of these patients are stage 3 as expected. Younger population, the rest is the same.
Similar, yeah. So, I was going through what is the data available on this. And in fact, this has been studied quite extensively. And this is one of the, I picked it from one of the papers, the heading of the paper itself was young age at onset in breast cancer in Asia. And it's very interesting to see the difference here. The peak is around 45, 50, the bigger peak is around that. But as they went on studying and they interpreted it, they said it is a cohort effect that is causing this skewing of the data rather than the incidence of breast cancer being more in the younger age group, because we have a larger younger population in these countries. Right now, as we go on, our population is aging. But in European countries, they have that, they have a lot of population which is already aged, and because of that cohort effect, the type of cohort which we are studying, we are seeing this kind of a skewed data, is what is their opinion. They may be right, because though we are right in what we are seeing, that our population or our breast cancer patients we are seeing at younger age, but they also are right in the sense that our population is predominantly younger. Now, stage at presentation is also a very important thing to see, and this is again from one of the papers from India, which says, again, this is urban data, which says about, as of now, as of 2020, we are getting more cases in stage 2, and next would be stage 3. So if you had seen similar data taken about 20 years back, it was predominantly stage 3 and stage 4. So we are slowly moving towards stage 2 and stage 1 as we go on. If you see the Western population, they are totally, they are moved to stage 1 and stage 2 predominantly. So there is a thing, as the population gets educated, awareness improves, we may see better or early presentation of the disease. Now, in our next few slides, we will be discussing based on a few cases. We will be discussing mainly 2 cases, and our whole discussion will be centered around how to manage these 2 cases. So I have case 1, a female, a 30-year-old young lady with breast cancer on her left side, actually. And the biopsy said it is an infiltrating ductal carcinoma, not otherwise specified, grade 3. It is a clinical stage of, she has a clinical stage of T2N0M0. So she has a very strong family history. Now, to my panel, the question is, what are the staging workups that you would do in your practice? So what are the main things you would do? This is the list which I have put across. Dr. Nancy, I'll start with you.
Okay, so this is a
Dr. Necy,
female.
sorry.
Yeah, yeah. This is a T2 disease, right?
Yes.
So my minimum staging workup it would be a CT. Also depending on the breast panel results. So patient with HER2 positive disease and triple negative who are candidate for neoadjuvant, then I'll go for PET CT. But if of course you have to consider the economics of the patient, we can have the minimum like an ultrasound, chest X-ray, and a bone scan. Well, it all depends on the stage and the molecular.
So generally, would you suggest a patient for PET CT only if the HER2 is, I mean, more aggressive diseases, you will prefer PET CT, but
Yes,
if this
yeah,
late
for
is not
patient who
very
have
aggressive,
high
yeah,
risk factor, you have a
yeah,
and for patient who are triple
yeah.
negative.
Okay. What about it? How do you practice in Malaysia, Dr. Ahmad?
Yeah, so my practice, I mean, I'm still relatively new in the Malaysia scene, but generally, we would look at the prognostic factors. So that would be a combination of the clinical, the histological, and of course, we haven't in Malaysia, we have not yet got the luxury of doing the genetic mutational testing, except for the histological subtyping. But
Okay.
if the patient has got triple negative breast cancer and some other high risk features, definitely, that patient would require the CT scan, chest, abdomen, pelvis at least. If the patient is HER2 positive disease, that's also the other indication to go for it. But if the patient is ERPR positive, HER2 negative breast cancer, and node negative, then usually we stop at doing the bilateral mammography and biopsy as the extent of the investigation.
Okay. Dr. Sudip, do you do anything differently from them or same?
No, actually is the same. But it depends upon where we are practicing. Like we have a center where there is no access of other things. That I mean, bigger investigations, and especially due to financial issues, the minimum investigation the doctors are doing before they do surgery in this case is maybe ultrasonogram, chest X-ray, and mammogram at the most. But like in the scenario where if we are practicing in the cities and or bigger hospital, again, just to admit that for last 1.5 years, 2 years, our PET scan is not working in Nepal due to, I mean, isotopes issue. So we do not have access to this. But other than that, we try to do most of the investigations, and we also we are at presently we are having outsourcing our this molecular test. So in some scenario, we do discuss with the family and do those tests as well.
Would anybody in the panel would like to comment on whether they would directly do a PET CT as a staging workup? Dr. Mandeep, yeah, you want to say something?
Dr. Sandeep, as rest of the panelists are, I agree with rest of the panelists that the staging has to be based on the prognostic factors, whether it's a ERPR positive, triple negative, or HER2 positive. And Delhi, obviously, the PET scan is now very much available, and the cost is very, very less. Like
absolutely,
if I had to get a CT chest abdomen, at the same cost I'll be getting a PET scan. That is the situation in Delhi at this point of time. So if it is a luminal A like ERPR positive, I would be just happy with an ultrasound since it's a younger female and X-ray chest. If it is a HER2 positive, triple negative, definitely I'll add a PET scan. It's like it's available, and also because of the aggressivity of disease, I feel that PET scan, specifically in aggressive variety, should be done.
Yeah.
But
so
its
I
availability
think,
also is an issue.
Exactly. So I think, if we go by the standard guidelines like NCCN, what they suggest is if it's a early disease, they don't really recommend a PET CT. They recommend only limited staging workup, but they recommend a PET CT only when a neoadjuvant chemotherapy is planned for that patient. Otherwise, the recommendation is to go directly for a definitive treatment if you are planning. So that is how they recommend. But having said that, these are recommendations based on the regional realities of United States, because United States, to get a PET CT appointment, it will take you, in fact, a lot of struggle. In fact, waiting time is too much. And in fact, where the resources are available, and the cost is not a constraint, like in fact in most of the urban cities in India, we are spoiled for our this thing. We have sufficient number of PET CTs. You're perfectly within your rights to go with a PET CT. But if your resources are limited, you could always consider doing by these guidelines. Dr. Nuradh, you wanted to add some point?
Yeah, I think so. In our practice, I have to say, for these kind of patients, T2N0, our experience is that we wouldn't do certainly we wouldn't do a PET CT in our practice, but even unless it's a very sort of more than say 4 centimeters. I know it's a sort of a young age group patient, but if there are no symptoms, in fact, there were several studies done by the oncologists here. They looked at routine staging. So unless it's not positive or more than 5 centimeters, we wouldn't do a formal staging. So for this patient, we would probably do, if possible, an MR mammogram, given the age. And if there is no symptoms suggestive of metastatic disease, we wouldn't do a formal staging. And we don't really do it based on biology either.
Okay. So do you, when you're telling that, would you divide the T2 into less than 4 centimeters and more than, because again, there is a thought process that the T2A does better than T2B. So now again, that divide comes there, because if it's a larger T2, would you benefit, in fact, still the patient may benefit by doing a PET CT going against the standard guidelines. Would you say that?
Yeah, so it's I guess it's a continuum, and so to dichotomize at a certain cutoff it's always hard. But so the difference that it would make is that if you detect metastatic disease, then your treatment, systemic metastasis, you would then go on. You would no longer offer curative intent treatment.
Exactly.
So I guess it's balancing the probabilities of detecting that in an asymptomatic patient. Versus utilizing your resources. So in our practice, we don't do routine staging for these patients. But I take the point that in this patient, given the age and the biology, there is a greater imperative to do so.
So in this patient, this is how the PET CT looked. It was a limited disease, it is about 2 centimeters growth or so, maybe just above 2 centimeters, no metastasis anywhere, looks good. IHC, coming to the immunohistochemistry markers, generally, overall, what are the immunohistochemistry doctor? Dr. Chowdhury, I would start with you.
Yeah, usually in our country, because we do ERPR, HER2, Ki67, these are the common which we actually do, because other are not available in the country, like what you have, and the ER and other things which are not available. So we commonly do ERPR and HER2 and Ki67 in our routine practice here.
Okay. Is there anybody in the panel who does more than ERPR, HER2-neu and Ki67? I think, that is a standard practice. Everybody follows these 3. But are there any treatment guide? I have seen some people doing androgen receptors on routine basis. Is there any treatment guideline? Is there any utility for such a test being performed? Dr. Ahmad, you.
Yeah, so as far as I'm concerned, there are issues with regards to doing the androgen receptor assays. One is it is not standardized between different laboratories, and the treatment using the androgen receptor inhibitor at this stage is still in the experimental and clinical trials phases. So at the moment, at least from the clinical practice point of view, there is no data to actually support doing that as a routine practice.
Dr. Mandeep, you want to add something?
Yeah, Dr. Nayak. Just wanted to add that agreed with you and the panelists that androgen receptor, obviously there's no data for that. and there's not much utility also, until unless we prove it's a triple negative, and then we look at whether we want to add androgen treatment later on, that too in a more advanced disease. We in our institute have started looking at doing GATA also, just that if we have a early disease and it's an N0 disease, so there is now some data coming out that GATA can also give us the predictability of a lymph node metastasis. That is still at the early stage.
Correct. Yeah. So that is one another marker. If this patient in IHC turns out to be, a good risk, ERPR positive, HER2 negative, low Ki67, would you send risk stratification at this time itself, or would you wait? How do you really manage in your? Do you do it? Anybody has any say on this? Risk stratification like Oncotype DX or any of that? Dr. Mandeep, tell me.
So I was just wondered, are you asking that before surgery or after surgery?
Before surgery, at this stage, because you have just done a biopsy, you got IHC. See, very often what happens is, the biopsy sample is the best sample to send for, any further analysis. That's one point which I wanted to make out here, because very often what happens is the final histology sample could have a time gap. They may not have followed the ideal management protocol for a histopathology, where it has to be put in the formalin within that 1 hour and to be removed within 48 hours. So ideally a pathologist would always recommend that a biopsy sample be sent for the further testing in case you want to send for higher tests. So I just wanted to make that point. But yes, it's a choice to send for risk stratification tests at this time if the ERPR HER2 new comes within or if this is a good risk case. Now coming to the prevalence of the hormone receptor status and the HER2 new status, how I think already somebody told me that we see less number of HER2 ERPR positives in the eastern countries. In fact, we have definite data for India that we are at least 20%, we have at least 20 to 30% lower hormone positivity rate, and our TNBC and HER2 rates are higher than the Western population. Is it the similar thing in other countries as well? What do you experience in, say, for we are talking about Philippines or Malaysia, a little farther in the east? How is your experience there, Dr. Necy?
With regards to the HER2.
Yeah. HER2 and TNBC, triple negative breast cancer.
So there's an increasing number of triple negative now. We all know that for HER2 positivity, it will be around 40%. With regards to this case, if I'm going to add the risk stratification test, since this is in a younger patient, there are now studies that show benefit of doing genomic assay to assess the risk of recurrence of young patients with strong family history of breast cancer. So either we'll add the breast BRCA testing due to the patient's history, family history, I mean. So that's another test that I would request also.
So I think I was coming to that. This I think we have covered already. Sorry, I think it came. Okay, this is the histopathology of this patient. Sorry, IHC, immunohistochemistry of this patient. So this was T2N0. This has turned out to be triple negative. You can see all the markers here. ERPR is negative, and the HER2 is negative
equivocal.
Equivocal, which is fish, and this is negative. So fish negative. So this is the overall picture. So she is triple negative disease, young patient with triple negative. I think Dr. Necy was pointing out that we would consider this patient for hereditary test panel, and the reason for sending it is any person who is, these are the guidelines. In fact, this is available. Any young patient or anybody with the triple negative below the age of 60 years definitely there is an indication to send for the genetic test to see whether there is any hereditary component. What type of test would you send in your practice? Is it just the BRCA or multi-gene panel or whole genome, whole exome? What do you really send in your practice? What's available to you? Dr. Necy? You were talking about it, so I'm just continuing with you.
Yeah, we usually send the patient for genetic counseling.
Yeah, okay. And
So
what is the
we
preferred test? BRCA alone or multi-gene panel?
BRCA alone for
Okay.
now, but of course, a multi-gene panel would also be helpful.
Okay.
But
How
of
is it?
course, if you I mean the cost, if you're going to consider the cost and the availability of the medicine, that's another problem.
Okay. What about it in Malaysia?
Yeah, so here it's on the case by case and discussion with patients, of course, because it is not funded as for the testing, and it is also not covered by the insurance companies. But if we are to recommend in the context of breast cancer, at this stage, it will be BRCA1 and 2.
Okay.
Because other potential pathogenic variant in terms of the utility might not be so much at this stage.
So, is there any other practice in common in, say, in Sri Lanka? Dr. Nuradh, you have any other opinion on this?
No, I think I agree with my colleagues. We would do a BRCA testing. Again, it's not funded in our state health system at the moment. But I think I would stick to BRCA for this patient.
How do you practice in Mumbai and this one, Dr. Sewanti?
Yes, sir. Routinely it's a multi-gene panel. However, I'm being influenced in terms of multi-gene panel. Mostly, we end up doing 25 identified genes. However, now I'm quite influenced that hereditary germline profiling should be a norm. And actually, I have come to believe that hereditary germline profiling should be done in every patient. So I practice, I direct a precision clinic, and that's something that I recommend for each one of my patients.
Irrespective of age, ERPR status and everything?
Irrespective.
Is it? Oh, okay, that's interesting.
Because I operate in advanced stages mostly, and my focus is identifying targets in a lot of this. It doesn't fit for this particular patient. Here I would do a multi-gene panel. But if in answering a generic question, if I were to look at advanced patient heavily pretreated, I would do a broad panel, both somatic and germline.
Okay, that's okay. That question is something different. So, right. So, is there anybody else practicing differently? Because see, in my practice, I always send for multi-gene panel, but in India, at least, at present, I don't see any difference between the cost. We have almost same cost, maybe a marginal difference for multi-gene panel. So, is there a difference in practice? If you can, any of you have any comment?
Yeah, I just want to make a comment on Nepal, what we do practice Nepal. As you can understand that we do not have this access to in our country as a whole. So most of the patients actually they do not go for that test. So there are many reasons for doing that. One is lack of awareness among the practicing people, and also amongst the patients, and as it is not available, and also cost issues. But now we have access to this. So like if for me, like I'm now it is giving most time to do counseling to the patients regarding this test available. And till few months back, we are doing this only BRCA limited gene this thing. But now this multi-gene panel, which has come in a very cheaper price, so we are offering them that multi-gene panel. Now I think in my practice, I am seeing more and more patients are open up doing this test, because now the benefit and options are so much.
Exactly.
So I try to convince the patients to doing that.
Yeah. So in fact, it is beneficial. Yeah, who's?
Just, yeah, Mandeep.
Mandeep, yeah.
Just, I want to add how I take these things in my practice. So definitely, as you rightly said, in India now the cost of a BRCA1, BRCA2 or a multi-gene panel is more or less the similar. In this case specifically, since it's an early disease, the treatment decision would basically be based on BRCA1, BRCA2, because we can offer bilateral mastectomy if it is BRCA1, BRCA2 positive, but any other multi-genes, we are still not contemplating any double mastectomies for when we are doing surgeries. So other other genes, even if they are positive, we are still looking at intensive screening. Had it been an advanced disease, I would consider multi-gene, because in advanced diseases, then multi-gene would help us to decide whether to add later on, if in adjuvant or in recurrent settings, to add PARP inhibitors or not. So multi-gene, yes, if given an option. If I'm looking at very precise treatment decisions in early stage, I would still order BRCA1, BRCA2. That is how I normally go about doing things.
Okay, so I think Dr. Ahmad at some point.
Yeah, so very quickly, I echoed Dr. Mandeep exactly that, because a couple of things. One is when do we do the upfront multi-gene panel? If we found PALB2 or ATM or TP53, yes, that's all great. We know that the prognosis might not be so good. That creates the anxiety among our patients population, and then we could not actually offer any new treatment at that stage. And that's the first thing. And the second thing as well is, some of the papers have showed that when you do the multi-panel testing upfront, and when patient actually progress on the early treatment,
no, I think Dr. Ahmad, I'm talking about a germline multi-gene panel, not the somatic panel here. So
I see.
There is a difference here, because in this is all hereditary panels. So I'm not talking about the therapeutic aspect of it. So when it comes to the germline panel, I think, if we exclude these, there is always a risk that we may miss some of the things, but there is no therapeutic guideline for these things. Preventive guidelines don't exist. So I think though it is available, sometimes it could be a problem for us to decide what to do, because I have patients with these mutations and we don't have therapeutic guide or preventive guidelines for these. So that is the point which I think we'll come to the other panel later on, somatic genetic panel. But continuing with Dr. Mandeep.
I just wanted to make a point, sort of a bottom line on what we are discussing. So what Dr. Mandeep said, I would like to reiterate that. I think BRCA1, BRCA2 for primary decision making is very, very critical.
Yes.
Ought to have that. Multi-gene panel at the outset becomes important or imperative, because you won't go back and do additional if you found BRCA1, BRCA2 negative. Why is that important? Mainly to how to follow the patient. What are the risks? Is there a risk of another malignancy? I've had patients who have PALB2 ended up with another malignancy, or RAD51B, ovarian and breast. So just from that perspective, you get a test done, you get it done one time, and you have the implications outlined. So that's it. Thank you.
Yeah, that's good. So Dr. Mandeep, would you send this patient now? She's at early disease. She's had, it's a small disease. It's not very large. Would you wait for germline to come, send for chemotherapy, or are you in favor of surgery? What is your practice?
So definitely I would wait for the germline to come. Specifically if it's a young patient, triple negative, very strong family history. So there are high chances that she might land up being a BRCA1 positive. So that will definitely influence my treatment decision, my surgical decision specifically. Second, another issue is that since it's a triple negative cancer, so I would anyway prefer to give a neoadjuvant chemotherapy, because then it would help me to differentiate between patients who are responders versus patients who are non-responders. So if my surgery ends up having a pathological CR, definitely her prognosis becomes very, very better. So that is the reason why I would prefer to give a neoadjuvant, specifically to understand the prognosis. Secondly, to understand whether it's a BRCA1 positive, so that I can plan my surgery accordingly. I can give an option of that patient of double mastectomy. Otherwise, when the surgery is done, then it's very difficult for us to tell patients to go ahead and get a surgery again.
Yes. So there is definite advantage in that if a patient is going for a mastectomy and prophylactic mastectomy, there is definite advantage in giving chemotherapy, but also that TNBCs, the current standard is to go for neoadjuvant chemotherapy, considering it is an aggressive disease. I think is the practice the same across the panel, or is there any difference in the practices? Dr. Sudip.
Yeah, yes. Unfortunately, again, I must admit the control is not in our hand. Like most of the time, you are referred a case, it's operated, so you don't have choice. But
Okay.
like in my institute, though it is a comprehensive cancer center, we have a MDT. So we now doing lots of practice on neoadjuvant chemotherapy. So all triple negative, they go for this neoadjuvant treatment. So again, like regarding waiting for this test, the turnaround time is more than 1 month. So, but if it is neoadjuvant, yes, it is. We do take advantage of this report, and before surgery, we do give the options of them of if BRCA positive, what to do and what not to do. So because the counseling takes a long time, because in 1 hour counseling is not enough. You have to do repeated counseling for any kind of treatment decision. So having a few months in advance, a few weeks in advance before surgery is very good for us to do counseling, repeated counseling for them to understand how important it is for to modify the surgery as per this, germline result.
Okay. So, Dr. Chowdhury, you have anything to say on this?
No, similar, because especially in the urban Dhaka cities, we had a MTD. So MTD comes up with a new adjuvant therapy, especially for the triple negative breast cancer, especially for doing the BRCA1 and BRCA2, because it takes a lot of times, and we had to send from Dhaka to neighboring countries and even in Europe. So it takes a lot of time. So we start with the neoadjuvant therapy. These are common things, and genetic counseling is very less here, especially. Yeah. So it's not that much practice here.
Okay. So see, as far as the surgical aspect of it is concerned, it is what guidelines say today is to discuss the pros and cons of surgery. We do prefer to give chemotherapy in TNBCs in upfront, but if there is a mutation detected later, again bilateral mastectomy should is an option for them, or else if the patient does not opt for it, it is a close follow-up, annual mammogram and MRI is what is recommended as of today. So this is the guideline, and this is what we follow. Very often the patients, this patient underwent BRCA. This is how her mutation was. She had BRCA1 mutation, pathogenic BRCA1 mutation, and this lady, in this lady again, the question goes back to the surgeon. I think he has already answered this: mastectomy versus breast conservation surgery. I think we had a brief discussion on this, and the option of both does exist with the patient. We have to remember patient has the primary say. We can never force a surgery on the patient. We can give them the option, because germline is positive. You have an option of going for mastectomy versus going for a breast conservation surgery. If you're going for mastectomy, bilateral versus unilateral or ipsilateral mastectomy is an option. And also, very importantly, remember, in BRCA mutations, ovary is also a problem, and there is no clear-cut guideline as to how to screen ovary. So it is always better to go for an oophorectomy and salpingo-oophorectomy. That is more important than going for mastectomy, because breast is easily screenable, ovary is not. So that is a very important point to be made over there. But if a patient has P53 mutation, this is a contraindication to go for radiation. So the patient has to go for a mastectomy rather than a breast conservation surgery, because these patients tend to have another malignancy just because of radiation. Another mutation is an ATM gene mutation. That is also a contraindication. So Dr. Nuradh, you had something to say.
Yeah, sorry, I just got disconnected a bit, so might have missed some of the discussion. But going back to the issue of, I think, neoadjuvant chemotherapy, I think another aspect to consider is the fact that this is node negative, and what do we do with the axilla? Now, so it is a T2N0. So post neoadjuvant sentinel lymph node biopsy, they certainly in Sri Lanka, our pathologists, we are still gaining experience in this. So this is a bit of a there is this debate on how do we manage these patients. So some do a sentinel lymph node biopsy prior to neoadjuvant chemotherapy. Some a few surgeons and few centers do actually do a post neoadjuvant sentinel lymph node biopsy. So that's an aspect as well. I think I would certainly I think it is imperative to do an MR mammogram in this patient, and also if you are before you while waiting for the germline results, I would get the radiologist to put some clips here, and because you're going to get a very good response here. So those are some of the other practical aspects in our setting.
Absolutely, absolutely. Because in fact, I didn't go into more of surgical details over here. Yes, all those practices. In fact, we do a lot of, in our practice, sentinel node biopsy has become a routine, but we don't do it prior. We usually do an ultrasound guided FNAC of the lymph node or true cut biopsy of the lymph node if it is suspicious. And then they send the patient for neoadjuvant chemotherapy. We don't do upfront sentinel node biopsy. Yes, that is also an accepted practice because it can be done under local anesthesia in a single sitting. We do it as a, we practice it together with the, resection of the tumor. So whenever we perform, so that is our practice. We have standardized that.
Excuse me, I have a
Anybody
small
else?
question.
Yeah.
Yes, I have a questions to the panelists. Like as you said, there's a TP53 and ATM mutation is contraindicated for radiotherapy. So how often we are practicing this this fact? Because we are most of the time we are doing this limited panel, so probably we are missing this fact. So why don't we do routinely multi-general gene paneling for all the patients? Because we might miss these two mutations.
Absolutely. In fact, this is one of the reasons why multi-gene panel is a better way to do than a single gene, BRCA1, BRCA2. In fact, we have totally stopped doing single genes. In fact, in my practice, I don't practice single gene at all. We always do multi-gene panel because of this reason, because we pick up something which was not picked up. In fact, see, BRCA1, BRCA2 is something which is picked up in the Western population. Our population, data on genetics is not available as of today. We are still in the process of developing it. We don't know how it is in Asia. So it is all the more important to do a multi-gene panel, according to me, than to do BRCA alone. And in fact, we are seeing so many, variation of unknown significance in our practice that, maybe if you rerun these things after 10 years, you may find many of these genes coming into pathogenic this one, because we need to publish our data. That is where our data will come finally. So we are looking into it. In my practice, we are looking at many of these things as of now, and we will see how it works out. So yeah, so this is as far as the first case is concerned. We have discussed about all these aspects. I think we have already covered. But if we are doing bilateral mastectomy, it is always better to do a nipple sparing mastectomy, nipple areola sparing mastectomy, because cosmetically the outcome is far better, and the the overall feel of for the patient is almost like a normal tissue. So that is very important. And yeah, of course, I have pointed out the other thing that we can consider breast conservation as well. So this is the second case, again, little advanced case which we are going to discuss, second and the last case. Again, this is a 64-year-old lady, breast cancer, IDC grade 3, and she's a TNBC as well, and K67 is 55%. We have clinically, she is T3N2A. So as a standard, I think, all of us will agree that we will prefer to have a PET CT. There's no confusion about that. But on PET CT, she has lit up like this. She is like a lantern, lit up across everywhere in the body, multiple metastasis, bone, she has liver metastasis, she has lung metastasis, there is multiple disease everywhere. So under the circumstances, I'm directly going, because this will be a shorter discussion. There is a lot of, we have to go for systemic therapy over here. I don't want to go into what are the choices, because this will be a part of various other discussions. It's available, they're standard. We would send, because she has a very, very strong history, we have sent her genetic test as well, and her genetic test is positive for BRCA mutation. So that also we have. So we are not going into that aspect as well. But because my question here is, because BRCA mutation is positive, would your treatment here, in your treatment, would it change in any way? Would you give the standard chemotherapies which the standard guidelines are talking about, or would you add anything else like the olaparibs and all those things? Do you differ? So it's so to the medical oncologist, how is it your practice, Dr. Qureshi? Sorry, Dr. Chowdhury.
Yeah, so usually in our country, actually, we start with a common chemotherapy practice, especially. Then BRCA is not always available here, so we start with the chemotherapy. Then we, when the BRCA1 and 2 comes, then we make as a second or third option in that case. As we start with the straightaway chemotherapy for that, especially the triple negative breast cancer with advanced cases, especially. We follow the guidelines what we have, especially the NCS and NCCN and others.
Dr. Necy, towards that side, how do you practice?
Yeah, it's we start the patient on the standard of care, either taxanes, but now that we have a immune checkpoint inhibitor plus a nab-pacli, very good duration of response with the Keynote 355. Now also show an overall survival benefit as well. Well, it depends on the patient preference, since she is over 60, and also depends on the access to this medicine. So if patient wants to forgo systemic treatment, we'll offer PARP inhibitor if patient is BRCA mutation positive. So that's the options.
Okay. Dr. Nuradh, anything different in Sri Lanka?
Yeah, so I think we have this issue of availability of PARP inhibitors. So if it's available, certainly I would offer that option. Regarding to chemotherapy, I generally do offer a combination of taxanes and platinums. I find that the toxicity isn't very much increased when you combine paclitaxel and carboplatin, particularly the weekly regimen, 3 weeks and 1 week off, kind of, so that allows you to, if there's some toxicity, you can always stop. So that has been in my practice. Of course, there is a lot of variability in this area, as you would imagine. I certainly, if it is triple negative metastatic, I would start on a taxane platinum weekly combination is my preferred option, particularly for patients of this age. But if so olaparib is available in sort of, there are times when it's available in the state and times when it's not. So the question is, if we do start, whether we can sustain that. So those are all practical issues.
Absolutely, yeah. Yeah, many, because of economic reasons, it is not easy to sustain as well. So how is it, Dr. Dr. Sewanti, sorry, I hope I'm pronouncing your name correct.
Dr. Sewanti is not here.
Not there?
No.
Dropped out because of maybe some connection issues.
Yes.
So anybody else has any comment on this, practice differences? Dr. Mandeep, you want to say something?
Yeah, Dr. Nayak, as you had slightly shown that slide, so getting a germline analysis and knowing that it's a BRCA1 positive, triple negative. So it enhances, since it's a metastatic disease, it's lit up like a lantern. So we would be more confident that yes, we should go towards vaccines and platinums, and there is a pretty high chance now we would anticipate that she might get a very good response with that. So
Correct.
that definitely helps us that rather than wasting patients' resources and our resources on. Some people might still consider starting with adriamycin or cyclophosphamide as if they were not available with this BRCA1 point. And if she, as expected, she might get a very good response. And depending on the availability and resources, we might maintain that response with olaparib so that both her quality of life and overall survival also increases by knowing this information.
Would you consider, NGS for somatic genetic mutation here? Any of you would consider it? Because as of now, it's something which is very dicey. Dr. Ahmad, you wanted to say something as well. You can talk about that and continue on this question.
Yeah, absolutely. So yeah, so in the disease progression setting, I think the NGS has got a role, but I think it needs to be put in the clinical trials concept. Because so for example, right, in the non-small cell lung cancer study, we've got the taper, we've got the capture, and then for example in Australia they're doing the comprehensive genomic profiling and do the mutational targeted therapy through clinical trials. So absolutely, I think there is a role of that in the clinical trial setting. And also to add to that, what I usually do in the clinic though is actually I try to develop a few pathways for the patient. So in this situation, it could be testing for the germline is positive, so there could be option of olaparib. But PD-L1 staining also becomes important because of the new Pembro Keynote 355 and atezolizumab. And one thing, of course, that actually would raise another confusion is what if this patient has got germline BRCA mutation positive and PD-L1 positive? So what would you do and what would be the line of treatment? So I think in that situation as well, having the molecular tumor board, if possible, developing over time could help actually guide our treatment.
Yeah. So I didn't want to get into that, but other targeted, pathways for, I think, we have covered this, what is the type of evidence which is there and all that. So, these are the targets which are available, and these can be tested with either your sequencing, the IHC marker, or we could always consider, next generation sequencing.
NGS.
NGS panel.
Or
and,
CGP.
Sorry?
Or CGP, you could.
Yeah.
Comprehensive genomic profiling.
It's the same thing.
Same thing.
Comprehensive genomic panel is done usually with next generation sequencing. So, the pembrolizumab, generally if PD-L1 is positive, but PD-L can be tested with NGS. And again, I think the restricting factor here is the cost. I think, as cost comes down, the test cost comes down and the therapy cost comes down, the two meet, I think it will be it will definitely be easier for our patients as well. So that is where the entire thing finally boils down to, because as of now, we see that, these guys, our this program, the Fortis Care, I saw that, they have crashed the rates significantly. They are able to give us at a very low cost. But what happens is, in practice, very often the therapy cost also should match for us. That is where our restriction comes into. Dr. Mandeep, you had something to say.
Yeah, I just wanted to share one experience with the esteemed panel. So we had a similar case like this, and we got a NGS analysis done. So our medical oncology team and we got into an IMDT gave the patient, since patient had resources. So it was a PD-L1 negative, but it had an high MSI burden. The tumor mutation burden was also very high.
Yeah.
So with platinum taxanes, we added pembrolizumab, and the patient had a very good response. And we also, with that NGS panel, we were able to understand that it was a PARP inhibitor was also effective, and also the PI3KC mTOR pathway is also active. So with a very good response of platinum taxane and a checkpoint inhibitor, we are, like I'm experiencing the patient, we are able to maintain the patient's response with a PARP inhibitor, and also we have added a everolimus to cover the other pathway. So this is something which I wanted to share, and which gave us the advantage of doing this kind of treatment. But yes, I really agree with you, Dr. Nayak, because the cost of the therapy also is pretty high.
Yeah, but still, if there is an option to send today, as of today, if test cost as the test cost is lower, I would definitely consider in a metastatic cancer. I would definitely consider NGS comprehensive genomic profiling. In most of the metastatic cancers, not only breast I'm talking about, I would prefer to do it as of today, because I was just going through the data for that. And yeah, Dr. Ahmad, you wanted to put something. You want to say something?
No, I think I completely agree that the NGS, it's the way forward. The only thing, though, I think as the medical oncologists and clinician scientists, we need to be aware as well. Although a lot of these cancer are being now treated as histologically agnostic, but we need to understand that the driver mutations in different histology, when it is targeted, could also behave differently. So, for example, BRAF V600 mutation in lung cancer and colon cancer and melanoma could have a very different response rate. So that's just a point to make. Yeah, absolutely.
Yes. Yes, that I completely agree. Just the mutation being present doesn't mean that it will behave the same way. I agree with you completely. So, in fact, this is some very interesting paper which I came across. In metastatic breast cancers, there is a when you do a comprehensive genomic profiling, there is a therapeutic marker that is available in nearly 60% of the patients. Mind you, again, this will include all the known commonly used markers as well. So if you remove that, I don't know how many of them are really newer markers, but generally about 60%, if you do, you would get the therapeutic markers. And this is the graph which they presented. And these are the markers which they are talking about. PIK3 CA marker, which in fact Dr. Mandeep was talking about, and HER2, of course, we know this is seen in about 26% here, yeah, something like that. So these are the markers which we are seeing, and this is is a good data, but I think more is required. But in the same paper, this is another research paper or an review paper. When should we order for NGS sequence for a patient? In fact, this is a very nice paper. I would recommend every one of you to read this. This is a new paper. It's published in 2020. See, when it is not indicated is in early cancers who are undergoing definitive therapy. It is definitely not indicated. It is not indicated in a rapidly progressing cancer where the performance status is very poor, and thus the short expected survival. You don't need to do it. It is not indicated. But in other cases, it can be considered, that is advanced lung cancers or some advanced rare cancers, or under the clinical trial or exceptional responders to treatment, where metastatic disease, the person is responding very well. In those scenarios, we could consider it as as a way to find a maintenance therapy as well. So these are the things. This is a good paper. If you find a chance, definitely read this. You can put this text inside, and you will get this paper. So another very important study which I think we all should be waiting for is this NCI match study, which is actually looking at 10 most common cancer, including breast cancer. They are looking at cancer genetics. They're doing NGS on all these cancers and see whether treating these cancers based on the genetic mutation would be useful. Is a precision oncology treatment better for these patients than to go for organ specific cancer therapy? So organ specific versus organ agnostic cancer therapy is what this study is studying, and this is an ongoing trial, and I am very keen to know the results of this. This will be very interesting. So overall, this is what is the conclusion. If anybody has any other things to talk about, they are welcome to raise their comments. Any of the panelists have anything to conclude from their side, they are welcome to talk.
Sandeep,
yeah.
Especially for the NGS is a very, I think it is reasonable prices in India, but is in Bangladesh we don't have these facilities. So I think there is a limitations in countries like ours, especially because we know the NGS has a very good things to diagnose. Especially if we start with the NGS in the initial stage, we can plan the patient. Especially, for example, we are doing lung cases NGS from especially from India, but for breast cases and other things, we are not doing NGS because this is very, very expensive. I think India has made a very cheaper way for doing the NGS, what we were commonly doing in, especially in Delhi and Bombay and other main cities in India.
Okay. Dr. Necy, any comments? You wanted to say something?
Yeah, I just want to ask how much is the NGS in your country?
Okay,
because it's so expensive.
Commercials, I think they'll come back. Let's keep. Yeah, they'll get
Okay,
back to you.
but I would just like to have a caution on doing NGS guided treatment. And you have to remember that NGS guided treatment selection should not supersede the standard of care treatment option.
Okay. As
in the
of today.
absence of controlled clinical trial, which shows
Absolutely.
superior benefit.
That's why I'm keen on looking at that match trial, which is a very good thing. They're in fact that's going to be a bigger trial. They're taking 10 different cancers. Let's see what the results will be. That's an ongoing trial. I'm closely watching that. Dr. Ahmad, any comments from your side?
Yes, I think my comment is actually would be the combination of when we look at more of the genomic profiling and genomic signature. I think capturing the granular data of our patients becomes so important. The reason for this, as you've mentioned, Sandeep, very earlier on, that in our region, our standard of care is not necessarily the international guideline standard of care. So we might have a few cycles of this treatment and then the funding becomes not available and then we don't know. And that actually could also affect the kind of the mutation that we receive, especially in the case of resistant mutation that develops. And for some of the cancer, what have been done is they try to cycle the treatments on and off and see whether they can protect against resistance mutation. So it would be interesting to collect prospective granular data and see at the clinical trials level what would be our kind of mutations that we see in triple negative breast cancer, and that could actually formulate new pathway to target the common mutation that we see in our triple negative breast cancer population.
Yes. Dr. Nuradh, any comments?
Yeah, I agree with what has been said. I mean, it remains prohibitively expensive at the moment. Yes. And certainly there is a need for both access to therapeutics as well as cheaper NGS testing if it is to be cost effective in our city.
Yes. Dr. Sudip, anything from your side? Any concluding remarks from you?
No. I think I agree to all the panelists, and of course, the financial issue and technical, I mean, expertise is the main issue for countries like us. So we're looking forward to be developed in our country as well in future.
See, there is one or two questions here. I think we are in the question answer. One is pure chemotherapy related. Will you use taxanes and carboplatin combination with olaparib concurrently or sequentially in TNBC with BRCA mutation? I think I'll pass it on to medical oncologist if any of you want to take it. The question is whether you'll use taxane carboplatin in combination with olaparib concurrently or sequentially. Who would take that? Anybody to take that question? Dr. Necy, you want to take?
Yeah,
Or
for
Dr.
this
Ahmad?
case, I will go first with the taxane first,
Okay.
followed by the olaparib.
Dr. Ahmad, anything you have to say?
Yeah, I probably would follow the trial design of the Olympia trial, and then taxane and maintenance therapy with olaparib. Although, again, in our setting, usually it means we start taxane, and then when we get the approval, then we add the olaparib.
Okay. And I think the other question is, you just mentioned organ agnostic testing. If you could please let us know if agnostic means covering all the indications. I'll take, see, when we talk about organ agnostic, that means, we are not talking about which organ the cancer is arising from. We treat it based on the, DNA mutation that the cancer cells have. So it may be from breast cancer, it may be from colon cancer, it may be from any sarcoma for that matter, based on which mutation that particular cancer is showing. We treat that particular mutation based on the targeted therapy for that particular mutation. Now, there are limitations. These are in nascent stages. Maybe about 5 to 10% of the patients where we do these tests will get benefited, if at all. But this is coming up. This is a very early stage tests which are coming up. So I think we have covered all the questions that have been. There were 2 questions here. So we have had a very interesting discussion, and we have overshot our time as well. So it was a very nice and very, it was a good round table discussion among us, because we didn't know each other, what are the situations in various countries, how the things are emerging. It is very interesting, and I thank the entire panel for participating and contributing so significantly. Thank you very much, and very good evening.
Thank you.
Thank you. Thank you very much.
Thank you so much. Thank you.
So I will also like to thank everyone for the participation, for giving us so much time and giving us in the information, sharing their experience from different countries. Thank you so much. Thank you, Dr. Nayak, for moderating the session so beautifully. I am looking forward for more and more such sessions in future and to learn from your experience. Thank you so much. Have a nice day.